Okay, hello everyone. Now we're gonna continue with medications against parasites, anti-parasitic medications. And the first group that we're gonna be talking about are medications against malaria. So here we have the presentation. Malaria is a parasite that belongs to the protozoa family. The highlight about this family of parasites is that they're the size of a cell. They are unicellular organisms. They're the size of a cell, and because of this, they are able to infect our cells. So again, unicellular. And the cell that this parasite loves to invade is a red blood cell. So malaria, unfortunately, is a very serious disease that kills more than 1 million people per year worldwide. Regarding malaria, we have two types. Malaria, there's actually four, but two, we're going to emphasize two of them on this chapter, and that'll be Plasmodium vivax and Plasmodium falciparum. We're going to start with Plasmodium vivax. This is the most common form of malaria. It's from the two of them, this is the mild form, can be self-limiting. So that means that regarding treatment, we go more by symptoms, fever, body ache, stuff like that. And we don't use specific drugs. The highlight of this Plasmodium vivax is that the symptoms peak and decline every 48 hours. So this is a patient that shows up to the clinic in a very bad condition, high fevers, body aches, weakness. Next day, symptoms go away, they feel better, and then the next day they relapse. Again, the high fevers, the body aches, the severe weakness, and whoever pays attention to this, they're gonna notice that there's a cycle. And then when we do a blood test, we're gonna find anemia, cell lysis. So what happens here? Like I was telling you, this parasite likes to invade red blood cells. So they multiply inside our body. When they're inside the red blood cells, the immune system cannot detect them properly, so the patient doesn't have symptoms. The problem is the parasite, will destroy the red blood cells. The red blood cell is destroyed. The parasites now are exposed to the immune system, and it triggers all the signs and symptoms of inflammation, a reaction against the parasite infection. And that's when the fever goes up and the body aches and all the symptoms that the patient explained to the nurse. But then the parasites, they hide again. And that's when the symptom goes down. And the cycle continues. So with this type of malaria, gonna see a very predictable pattern once we identify how often the symptoms they repeat themselves. With Plasmodium falciparum, okay, it's more severe, and 10% of the victims will die if we don't treat them properly. This malaria can destroy up to 60% of the red blood cells circulating. So this patient has severe anemias. And here the patterns are not as obvious as the previous parasite, P. vivax. They're a little bit more predictable. They don't follow a specific pattern. Symptoms can increase 72 hours and then 48 hours and so on. So they don't follow a specific pattern. But the one thing that we notice right away is the severe anemia. So, like I was telling you, regarding the life cycle of this parasite, is inside and outside the red blood cell. When the parasite is inside the red blood cell, that's when they are more easy to kill, versus when they're outside, exoerythrocytic form are more harder to kill. The parasites, these are, we can say those are the tiny eggs. Every time a parasite divides, they lay out a bunch of eggs, and that's what we call sporocytes. And because they're on a egg life cycle or egg shaped form, they have this capsule that protects them from other drugs in order to get killed. So because of this, the treatment is divided in three parts. First is to treat the acute attack, prevent a relapse, and prophylaxis. If I only treat the acute attack, I'm going to have a relapse. So I have to be careful that once I identify or make a diagnosis of malaria, I need to treat what is happening right now. I need to prevent the relapse, and then I have to do a prophylaxis stage, because eventually these spores from the parasites, they're going to hatch, and I don't want them to do any symptoms, to produce any symptoms on the patient. So regarding the drugs that we're going to be talking about, we have chloroquine, primaquine, quinine, mefloquine, quinidine, artemisinin, derivatives, atovaquone, and proguanil. So you notice most of them, they have quin or sound like quin in their name. So every time we treat malaria, the treatment is, well, treat the patient and use medications that has no resistance. So we're going to start with chloroquine. Chloroquine is always the first medication we're going to start using. So it's our drug of choice. Very effective when the parasite is inside the red blood cell. Not too much when the parasite is outside the red blood cell. And also can be used for prophylaxis. The doses are low, and the only time we use a high dose is only when we have a spike in the symptoms and we want to kill as many parasites as we can. Now, regarding and how they work, chloroquine and all the other quins, what they do is, especially inside the red blood cell, they change the pH inside of it. They make it more acid. And also, by changing the pH inside the red blood cell, they inhibit or they block the movement of oxygen. So what does this mean? I have a parasite that is inside my cells, and the reason we call them parasites is because they take advantage of the hostage they invade. They use all the resources that they have, like oxygen and nutrients, for them to survive. So when the parasite is inside the red blood cell, and we know red blood cells are able to transport oxygen, they take advantage of that, and they take the oxygen for their advantage. So chloroquine and all the other quins, what they do is they go inside the red blood cell, they change the pH inside, make it a little bit more acid, and that makes it more difficult for the parasite to grab the oxygen. No oxygen, parasite dies. So that's more or less as a quick review on how this group of medication works. Now, chloroquine is the presentation is PO. Then I'm gonna have MVD. Patient may complain about visual disturbances, blurry vision, stuff like that. But I have to be careful with patients that have liver damage. Again, this is a medication that is altering the pH of a cell. So if for some reason this red blood cell is destroyed, the cell membrane is destroyed, that acid is gonna get out, and the liver, kidney are the ones in charge of changing all that. So that will cause liver damage. Same thing because of the destruction of red blood cells. Patient may complain of itchiness, and that's because of the bilirubin that is inside or is part of the red blood cell. So that can cause itching and headaches. Regarding Primaquine, this one is used for it says here hepatic form of malaria. So this is the other term that we are using instead of erythrocytic form. And here is where the parasite is multiplying, laying out all the little spores. So Primaquine is the best one when we have this type of presentation of the parasite, and the adverse effects is hemolysis. So what happens? Primaquine inhibits this enzyme, glucose-6-phosphate, in the red blood cell. So in other words, we are not letting that parasite use the oxygen that is inside the red blood cell. Unfortunately, the red blood cell cannot use it either, and that will make the red blood cell burst. Too much acid now inside the red blood cell. Quinine, just like chloroquine, is very good for the erythrocytic form of malaria. Quinine is used only for severe malaria, and we can mix it with antibiotics like doxycycline, tetracycline, or clindamycin. We already talked about this one on previous chapters. Same thing. The main adverse effect will be hemolytic anemia because they work the same. They inhibit the uses of oxygen. So the parasite doesn't have it, and unfortunately, the red blood cell cannot have it. There's an increase of that acid inside the environment of the red blood cell, and that will make it burst. Quinine is contraindicated on patients that are pregnant. Quinidine gluconate, this is the PO presentation of quinidine. The highlight, unfortunately, is cardiotoxic. It's gonna produce arrhythmias. So patients taking this presentation, they're gonna be taking EKGs as follow-up and constant blood pressure monitoring. And just like the regular quinidine presentation that we mentioned, quinidine gluconate has to be, or is advised to be given with tetracyclines and clindamycin. Methylquine, this is a drug that is used for prophylaxis in areas that we know that we have a chloroquine resistant strain of malaria. Ketoconazole, we already mentioned, is an azole. And this, the first time we saw ketoconazole is on the antifungal chapter inhibits CYP3A4. We mentioned this enzyme is located in the liver. So if I inhibit an enzyme that is able to metabolize methylquine, methylquine is not going to get inactivated. So that means that it's going to last longer. It's going to stay longer in the blood. As a consequence, I'm going to have increased levels of methylquine, and that's going to help me eliminate or prevent infections by malaria. Regarding the artemisinin derivatives, arsenate, the most common one. This is for uncomplicated malaria. Well tolerated. The only thing that I may add is if the presentation is PO, the adverse effects will be MVD. Atovaquone mixed with a proguanil. This one is used as prophylaxis in areas where I already have a chloroquine-resistant malaria. Atovaquone and proguanil are very good in the two cycles of malaria, inside and outside the red blood cell. And as a special mentioning, atovaquone by itself is used in cases of pneumonia for pneumocystis jirovecii. We mentioned this pneumonia was mentioned on the chapter of sulfonylureas. And this type of pneumonia, unfortunately, is very common on patients with HIV. So when we were talking about this pneumocystis pneumonia, we mentioned that the treatment was a sulfonylurea, sulfamethoxazole. But here we can add that atovaquone can be also used to treat this type of pneumonia if the antibiotic doesn't work. Even though malaria is a parasite infection, protozoa, we have noticed that tetracyclines like doxycycline and tetracycline can be used with the antimalarial drugs, and we have a better effect and less resistance against the treatment. Regarding tetracyclines, the highlight, already mentioned it a couple of times by now, is not given to pediatric patients or pregnant patients. Why? Because tetracyclines, they love to attach to calcium. So if the patient is pediatric with a fetus, the tetracycline is going to attach to a calcium that is supposed to be in the bones. So it's going to take it away from there. And the patient, regarding skeletal system, is not going to develop properly. Regarding tetracyclines, it's a medication that is heavy on the stomach. So it's advised, hey, you know what? You can take it with a snack. You can take it with meals. But we have to emphasize, don't take it with dairy products. So you can say, hey, I can take it with cheese. Here on the border, I can take it with a quesadilla. No, because the tetracycline will attach to the calcium of the cheese, to the calcium of the milk. This will make a bigger molecule to absorb, and it's not going to happen. The attachment or the attraction of tetracyclines with calcium is called chelation. Just in case they use that word in your test. Chelation. That's the attraction of tetracyclines with calcium. And same thing regarding drug interactions. Tetracyclines are not advised to be mixed with other drugs that have minerals in them, like aluminum, magnesium. We mentioned this the chapter of antacids. Regarding clindamycin, it's a medication that is used a lot too on this PO presentation. So regarding adverse effects, can be MVD, also very heavy on the stomach. So we advise to take it with snacks or with a meal. Regarding malaria prophylaxis, it's advised that people going to endemic areas, if they say, hey, I'm gonna go to Africa to a safari, and they mention or it's known that the area has malaria, it's advised for them to take prophylactic treatment 1 week before leaving, excuse me, and then 2 weeks after they come back from the trip. So that's a question that I saw a couple of times already regarding a prophylaxis treatment on patients going to endemic areas. Okay, thank you very much for your attention. I'll be seeing you soon on the next chapter. Thank you very much.